Hello and welcome to another episode of EHA Unplugged. Our special guest for this episode is Professor Carlos Fernández de Larrea from Barcelona. Professor Carlos is an expert in CAR-T and he is also in charge of the Myeloma CAR-T cell program in Hospital Clinic Barcelona. Given his expertise in the area of CAR-T cell in myeloma, we are here today to ask him a few questions on the clinical management of CAR-T cell therapy. So, listen on and enjoy the podcast.
I am Carlos Fernández de Larrea. I am a physician working in the amyloidosis and myeloma unit in Hospital Clinic Barcelona and also in charge of the myeloma CAR-T cell program there.
So what are the main toxicities we see in CAR-T cell treatment in myeloma?
The main toxicities when treating patients with CAR-T are the immune complications, basically the neurotoxicity, usually acute toxicity, and the cytokine release syndrome. We have several strategies to control mainly drugs such as tocilizumab, blocking the IL-6 receptor, the interleukin-6 receptor, and also glucocorticoids.
For the main toxicities, namely cytokine release system and neurotoxicity, do we have patient management guidelines for these?
For these two complications, cytokine release syndrome, CRS, and the neurotoxicity, usually under the acronym of ICANS, we have an international validated grading system according to very easily variables obtained usually in the clinical setting. With that, we have also a standard recommendation, for example, in Europe, how to manage according to the severity of the CRS or the neurotoxicity, particularly in the lower grades. It's true that we are going to the more severe complications, the management is more heterogeneous, and always the expertise in this field is crucial.
Are there different toxicity profiles between the different CAR-T products, and are there any differences between the usage of CAR-T in different hematological diseases, in terms of toxicity?
There are different frequencies and severity of the adverse events in terms of CRS and neurotoxicity according to the disease, lymphoma, acute lymphoblastic leukemia, multiple myeloma, and particularly due to the CAR-T used. For example, if the CAR-T is against CD19 or against BCMA. For example, neurotoxicity is clearly less frequent in CARs against BCMA than in CARs with against CD19, and CRS is also in general in a lower grade. However, cytopenias after the use of CAR-T and even macrophage activation could be more frequent in patients after treatment with BCMA. Also, some rare complications as a late neurotoxicity with movement disorder like a Parkinson's disease could develop sometimes after BCMA CAR-T cells.
For myeloma patients that would like to receive treatment, what are the eligibility criteria for them to receive treatment?
The eligibility until now in Europe has been in general related to the clinical trials available in the region. However, in outside clinical trial, the population is broader, and there are some limitations for the indication of CAR-T cells. In particular, of course, in many of our countries about the reimbursement. However, the age is not a limit, but it's important to have a good renal function because the lymphodepletion regimen is based on fludarabine, and we need a good renal function for the lymphodepletion. And we have a general good cardiac, neurological, and pulmonary function in order to tolerate the possibility of severe cytokine release syndrome, CRS.
can CAR T-cell therapy be considered for those that are not suitable for allogeneic stem cell transplantation?
There are patients that are not suitable for allogeneic stem cell transplantation, even not suitable for autologous stem cell transplantation, that can be suitable for CAR T cells. Due to in general, the lymphodepletion regimen is well tolerated, and the toxicity is usually limited to the first days after the infusion. And in general, patients are out of toxicity after 3 months, and they don't need any, for example, immunosuppression.
To sum things up, we currently have certain toxicities and complications in CAR T-cell treatment in myeloma. What can we expect to see in the future? Are there new approaches being explored in reducing toxicity? Can you tell us something about that?
There are several mechanisms that have been explored to reduce the toxicity in patients with CAR T. One could be to use, for example, CAR based on 4-1BB, as we are using in multiple myeloma. They have lower neurotoxicity, but they have, of course, the CD28, they have other advantage, in, for example, lymphoma patients. The other option could be also to use prophylactic agents, as to use tocilizumab, siltuximab, anakinra, or even corticoids in a prophylactic manner in order to avoid the development of a CRS. Studies are still running in this sense. The other option will be also to use new drugs of a tyrosine kinase inhibitor, as dasatinib, to regulate the expansion and the proliferation of these cells in a transient manner that can control or even to avoid also the development of these complications. Okay?
Thank you so much,